We are going to speak about booking visit, which is a very important station which may come to part 3 exam. And I'm saying it's very important because it has lots and lots of patient safety issues. So we are going to speak about booking visit in general today, and with other videos I'm going to speak separately in different medical problems or high risk pregnancies, and I will tell you specifying things related to these diseases. Okay, so first of all, we need to know that the proper timing of the booking visit, it should be done before 10 weeks of pregnancy. However, sometimes you may face in your exam a patient who came for booking, but she's, for example, 16 weeks of pregnancy or 20 weeks of pregnancy, and she didn't come ever before. We call them late booker. Okay, so what we are going to do with the late booker is the same if as if she came early in pregnancy. So we are going to do all the screening tests, and we are going to offer her all the scans and all of the things needed to be done. But before going ahead, we need to know why didn't she come before, because we need to exclude things which is very very important and sometimes may carry some risks. So these late bookers, usually we see them in teenager pregnancy, and these people may be still young, they don't know the importance of booking in this pregnancy, or it may be unplanned pregnancy and they need to just manage before they come and seek advice. So that's one of the things. The second thing, complex social issues, like for example, if the patient is immigrant or asylum seeker and she can't understand language and she's not able to communicate, so in that case we need to offer her support, and we offer her as well an interpreter so that we can communicate with her. And also it can be domestic violence. Maybe the patient is exposed to domestic violence, her partner doesn't allow her to come to the hospital or anything like that, so we need to sensitively screen for that. And also maybe the patient is having substance misuse, and she knows that once she comes to the booking visits we will advise her to stop, and we will refer her to um, um, like a specified person to deal with her, or she may afraid to come because we may do the urine toxicology and know that she is having this substance misuse, so they will neglect their appointment and not attend. So once you diagnose a patient coming for booking late, we need to know if there any specific reason before going ahead with the history. Okay, so the patient is here for booking today, so what we need to do during this visit. So first of all, you have to put in your mind 5 things to be done: history, examination, investigations, discussion, and plan of care. Okay, so history, I have a separate video for taking a proper full history. I'll put the link in the description, but I'll tell you in this video what issues we may need to stress on during the booking visit. Okay, we need the full proper history because we are seeing the patient for the first time. Even you can ask the patient and take her permission to review her medical records from the GP side, like if she is taking any regular medication for anything, because we assume that if the patient comes to you in part 3 exam for booking, that means she is a very high risk patient, because if she is a low risk patient, this booking visit should be done by the midwife. Okay, so she's a high risk patient, she may have a medical problem, pre-existing medical condition, or she's high risk for anything. So we need to take the full proper history and pick up the risk. They will sometimes they will not say what why she's referred. Okay, so that is the history. The examination, the only important thing in the booking visit in terms of examination is the BMI. If you told everything about the examination, like if you tell the patient, I will examine your vital signs and observation, I'll examine your chest, I'll examine your tummy, I'll examine your legs, everything is irrelevant in the booking visit apart from the BMI. Why? Because if the BMI is more than 30, we need to take action. So if BMI more than 30, I need to give her folic acid 5 milligram, and I will offer her a screening GTT, additional screening. So if you missed this part in the booking visit, this is a patient safety issue, because you will miss giving her the folic acid of high dose. And after the examination coming is the investigations or the screening tests. We have routine screening tests, which are bloods. I will let you know what kind of investigations we need to do during the booking visit soon. And then we need, after all of that, so history, examination, investigation, we need to discuss what we need to discuss about her medical condition, why she's here today. Like, for example, she is referred to you because she is known a cardiac patient, okay, and she's having unplanned pregnancy. So we need to discuss about her condition. How is the optimization of her condition before this pregnancy? Is it a planned pregnancy? Have she seen her doctor recently? Is he aware of her pregnancy? And is it safe to continue this pregnancy or no? That's because some patient may came to you with unplanned pregnancy. However, the pregnancy continuation is unsafe. It may be serious. For example, if we have like Marfan syndrome with a very dilated aorta, and she came pregnant, unplanned pregnancy, and before she has been advised by her doctor not to get pregnant, and she came pregnant. So what we need to do, we need to offer her options of continuation of pregnancy or medical termination of pregnancy, and give her the choice after explaining all the benefits and risks of both options. So if you didn't mention that there is an option of termination because this is a risky condition now, you will miss a patient safety issue, because you didn't assume that this pregnancy is going critical and put her life at risk. Okay? So we need to discuss the condition, the medical condition, the control of her condition. For example, if she is hypertensive on medication, how is your blood pressure control, what medication are you on, and everything is fine. Then we need to discuss two things: the effect of this condition on pregnancy and the effect of pregnancy on this condition. Okay? And if we need to modify any of your current medication, if it is unsafe to be taken during pregnancy. For example, if she is hypertensive on ACE inhibitor, that should be changed as soon as possible. Once we know that she is pregnant, then we may need to change her medication to a more safer medication. Okay? So we will discuss that with each case in the stations. So after we discuss all of that, we need to plan our care. Our care is not only the antenatal care. We need to plan for the antenatal care, we need to plan the perinatal period and the intrapartum, and as well as the postnatal care plan. So we need to do like a proper plan for everything, and also don't forget to discuss about any thing needed to be done for the next pregnancy. Like, for example, if this patient is epileptic on medication and she has got unplanned pregnancy, so she wasn't use a folic acid before her pregnancy, so she's at high risk of having neural tube defect during this pregnancy. So I'm going to offer her right now folic acid 5 milligram to continue till 12 weeks of pregnancy. However, I didn't prevent the risk because she came she came now around 6-7 weeks pregnant. So I don't know what happened before that. So I advise her for the next pregnancy, you should start your folic acid at least 3 months before your planned pregnancy. Okay, so like that. So if we need anything in the next pregnancy to be done, also should be discussed here. I know it's a lot of things to be done, but do as much as you can, because all of these information will give positive points in patient safety module. Okay, so while we are taking the history, I told you that if you want to revise how to take a proper full history, I'll put the link in the description. And then we need in the booking visit specifically to stress on any regular medication she is on, and whether they are safe to be taken during pregnancy or do we need to change them. Okay, then the control of her medical condition and like the follow-up with her doctor, if they are aware of that she's pregnant or no. Like sometimes she's like type 1 diabetes with long-standing retinopathy, and she's not advised to get pregnant, and then she get pregnant and she came to you, and then she didn't notify her doctor. So we need to refer her straight away to get checked and to let them know that she is pregnant. Okay, and specifically in the booking visit, don't forget to ask about smoking, alcohol, and recreation drugs. And this is where we need to offer NHS stop smoking and alcohol program. So if you offer these, the patient has the right to accept or decline. Okay, but you need to offer during the booking visit. Okay, we need to exclude domestic violence, and that should be in a sensitive way, and these questions shouldn't be asked in front of the partner. We should select the earliest possible situation where the patient is alone, and we need to ask her sensitively, is everything is all right at home? Do you have a proper support at home? Like that. Okay, and also screening for mental health issues. The mental health issues should be explored well during the booking visit, because we are seeing the patient for the first time. Some patients may have already an anxiety, depression from before, and they don't think that it may influence her pregnancy. So we need to ask her any do you feel in the last 4 weeks, do you feel more anxious than usual? Do you feel loss of interest of doing things that you used to do before? And what about your sleep pattern? What about your appetite? And what do you feel about this pregnancy? Are you happy for this pregnancy? Don't forget to congratulate her in the beginning when you meet her. Okay, so these kind of things we need to stress on while we are taking the history in the booking visit. Okay, so we need to remember to offer any of these 4 important things if they are required. First of all, high dose of folic acid. Okay, so I'll tell you later, like now, when we need each of them, but I need to just collect what we need to remember all together. So high dose of folic acid, so that's a medication which is taking up to the from the beginning of pregnancy or even before, till the end of first 12 weeks of pregnancy. So these 12 weeks finished, we'll start the aspirin. So aspirin should be started from week 12 till the delivery of the baby. So folic acid and aspirin, okay? And then low molecular weight heparin. You may need to offer the patient low molecular weight heparin from the first trimester in certain situations and from 28 weeks in different situations. So if you forgot about low molecular weight heparin, that is a very serious patient safety issue. So we need to know like when to offer this and when to offer this. Anti-D, if the patient Rh negative, don't forget that she may need an anti-D dose at 28 weeks if her baby is expected to be positive. Okay, so again, these 4 things are very, very important. High dose of folic acid, okay, is not necessarily we need to remember the high dose of folic acid. You need to remember folic acid in general. So we'll give all the low risk patient 400 microgram, but the high, I stressed on high dose because we need to know when to increase the dose to 5 milligrams, okay? So high dose of folic acid until week 12, aspirin from week 12 till delivery, low molecular weight heparin either from the first trimester or from 28 weeks or even postnatal. Some ladies may need only postnatal Kilixin, and anti-D at 28 weeks if Rh negative and her baby is expected to be positive. Okay, so which patient will need high dose of folic acid? So as I told you, folic acid 400 microgram once daily should be offered to all low-risk pregnancy while they are planning for their pregnancy and during the first 12 weeks of pregnancy. The following conditions only should be offered 5 milligram instead. First of all, epileptic patient on treatment, because the anti-epileptic treatment will affect the folic acid absorption, and that put the patient at risk of having baby with neural tube defect. So it's very, very important. Second is BMI more than 30, and that is the guideline. So if the patient is having BMI more than 30, she should be offered folic acid 5 milligrams and GTT. Then any patient with a previous baby with neural tube defect, or the patient herself having neural tube defect, like if the patient herself having a spina bifida, for example, then I need to give her folic acid 5 milligram from the beginning of her pregnancy. If the patient herself has a previous baby with neural tube defect, like baby with anencephaly, for example, or a baby with a spina bifida, then she needs folic acid high dose in the next pregnancy. Patients with sickle cell disease, and we will talk about it in a separate station, okay? And patient who was receiving methotrexate in the previous 3 months before her pregnancy. For example, patient who had an ectopic pregnancy treated medically with methotrexate and suddenly got pregnant within the next month without taking any breaks. So she should know that this methotrexate may decrease the absorption of her folic acid because it has antifolate effect, so we need to give her high dose of folic acid. Okay, so these are the conditions where we need to remember that the folic acid should be increased to 5 milligrams. Okay, so after the first 12 weeks passed and we finished already the folic acid, when to think about aspirin from week 12 till the end of pregnancy or till the delivery of the baby. So which patient will need aspirin? The patient who is at risk of preeclampsia. Okay, so which patient is at risk of preeclampsia? Any patient with previous hypertensive disorder in pregnancy, whatever it is, preeclampsia or just gestational hypertension or any hypertensive disorder during the previous pregnancy, we should give her aspirin in this pregnancy. Okay, and if the patient is already having chronic hypertension, then she is at risk of superimposed preeclampsia, so we need to give her aspirin. If the patient is having chronic kidney disease, she should be given aspirin. If the patient is having pre-existing diabetes mellitus, why? Because diabetes, when it is long-standing or pre-existing, that will cause some vasculopathy, and this vasculopathy can cause hypertensive disorders during pregnancy. So it can predispose to hypertension. So if the patient is diabetic from before pregnancy, we need to give her aspirin from week 12, okay? And if the patient is having autoimmune disease like systemic lupus erythematosus or antiphospholipid syndrome, because these autoimmune diseases sometimes cause vasculopathy and also precipitation of autoimmune complex, and also they cause nephropathy. So we need to consider giving them aspirin, okay, because they may also predispose to preeclampsia. So any patient of these, don't forget to offer aspirin from week 12 till delivery of the baby, okay? So which patient will need low molecular weight heparin? From the first trimester. So any patient with previous event of VTE, like if the patient came to you during the booking visit and she told you, I had previous DVT while I was 15 years old, like that. So this patient should receive low molecular weight heparin from the first trimester, okay? So any previous event. Or if she got a risk score of 4 or more, she should be given from the first trimester. And you need to refer to the guidelines of VTE risk assessment to see how many risk factors needed to be offered, antenatal or from 28 weeks. So 28 weeks if she has only 3 risk factors, from the first trimester if she has 4 risk factors, or if she scores 4, okay? So what are the screening tests we need to do during the antenatal care? So we have screening tests which is done for every pregnant patient. Some are during the booking visit. The first one is we'll take some bloods during the booking visits. We'll screen for full blood count, blood group and RH, hepatitis B virus, HIV, syphilis, and screening of thalassemia and sickle cell anemia. And these are done during the booking visit for every patient, whatever the gestational age. So if you face a patient in your exam who is like 20 weeks and came for booking visit, don't forget to collect the blood for these investigations, because this is a very, very important patient safety issue, okay? The other investigations which may come during the antenatal care, so the screening for Down, Edward, and Batou syndrome, which is a combined test, that if the patient has her booking visit as normal before 10 weeks, so we should plan these combined test between 11 to 14 weeks. But if the patient came as late booker, we may need quadruple test, and that should be done from 14 to 20 weeks. That's only if late booker, and the efficacy of or the predictive value of quadruple test is lesser than the combined test. So it's better if we do the combined test, but if she past 14 weeks, we cannot do it. We need to do the quadruple test. What if she came after 20 weeks? There is no Down syndrome screening after 20 weeks, and is only the anatomy scan to exclude any other feature. So she may skip her screening if she comes after 20 weeks. So we need to do another full blood count at 28 weeks, and with each visit we need to do urine dipstick. That's to exclude proteinuria, okay? So there are some additional screening tests to be done for a specific situation. The most important one is the oral glucose tolerance test, which is not done for everyone. It's done only for a specific group of patients. and it should be done between 24 to 28 weeks. So if the patient is having previous gestational diabetes, if the patient is having previous large baby more than 4.5 kilograms, if the patient having family history of diabetes with a first degree relative, and if her BMI is more than 30. So these only the categories which may be offered oral glucose tolerance test between 24 to 28 weeks. However, you should be aware that if the patient is having previous gestational diabetes, she should be screened twice during her pregnancy. First screening should be during the first trimester, usually around 16 weeks. And if that is negative, she should be screened again in the normal timing, which is 24 to 28 weeks. Sometimes we may need to consider oral glucose tolerance test in a patient who is low risk from the start. However, she developed some suspicion that she may have the diabetes. So if the baby measures big during the symphysiofundal height and confirmed by scan, so we need to screen her. Or if she continue to have glucose in her urine dipstick, like if she got +2 glucose in her urine dipstick, we need to screen her. Or if she got +1 twice in her urine dipstick, we need to screen her as well. If the patient is having polyhydramnios or any symptoms that may suspect that patient may develop gestational diabetes, then we may need to do a quick screen. However, in the booking visit, we need to know these categories, and we need to plan that you will be offered a GTT between 24 to 28 weeks. But if she's previous GDM, as I told you, she should be screened once in the first trimester, and then if it is negative, she should be screened again at 24 to 28 weeks. Regarding the scans during pregnancy, so you can imagine that in the UK, we offer only 2 scans in pregnancy. So the first scan will be dating scan and nuchal translucency measure. So that will be performed between 11 and 14 weeks, and they will see everything in this scan, like dating scan. They will measure the nuchal translucency if the patient opted for down screening. They will see the viability. They will see the number of pregnancy, like if it is twins, like intrauterine, like everything in this scan, okay? And the second and last scan will be at 18 to 20 plus 6, and that is the anatomy scan, or we call it anomaly scan. And at the same time, we see the placental location. So if the placental location in the anatomy scan came as a fundal placenta, then there is no need for any further scan during the whole of pregnancy, on condition that this pregnancy is a low risk. However, some patients may need additional scans. So these additional scans can be one of these 4 scans. The first of them is the viability scan, which may be performed between 7 to 9 weeks. And it is done when we have one of these conditions. First of all, recurrent first trimester miscarriage. Second, recurrent ectopic pregnancy, IVF pregnancy, pregestational diabetes on insulin, or any symptomatic patient which may have abdominal pain or vaginal spotting. And it is done only for reassurance and the viability. Okay? Another form of a common thing, which is the serial growth scans. These are third trimester scans. We start them anywhere after 24 weeks, like either at 24, 26, 28, and we do them like every 3 to 4 weeks till term, and these are done in any high risk pregnancy which may have an impact on the fetal growth. So usually most of our cases in part 3 exam will need serial growth scans, unless I told you she will not need. So we will discuss every case separately, but most of them will need serial growth scan during the third trimester. Okay. Placental location scan at 32 weeks. These when the patient have a low-lying placenta. At 20 weeks scan, so we need to offer her another placental scan at 32, and the fetal echo at 18 to 24 weeks. These patients who need to be sure that the baby doesn't have any heart problem, any congenital heart problem. If the patient herself born with a congenital heart condition, she's high risk to have a baby with a congenital heart problem, so she will be offered fetal echo. If she has a previous baby with congenital heart problem, she will be offered the fetal echo. If she's type 1 diabetes on insulin, because she may be at risk of fetal heart problems. If the patient receiving any specific medication which may have an impact on the baby heart, like lithium, warfarin, and anthracycline. Okay? So, planning for delivery, and unfortunately I don't have clue how to recognize and remember everything. However, I collected them in one slide. You can take a screenshot and save them by your heart, because if you didn't offer the patient induction of labor at a proper date according to her condition, that is a very important patient safety issue. So we assume that all low risk patients will wait for spontaneous labor up to 41 weeks. However, we may need to induce the patient if she's high risk. So our aim for everyone is vaginal delivery, unless I told you otherwise. So the time is the tricky thing. So when you have a patient and you plan for her antenatal care, you should know when you will deliver her. So if the patient is having monoamniotic, she will deliver by cesarean section at 34 weeks. If the patient with monochorionic twins have twin-to-twin transfusion, she will also deliver at 34 weeks. If the patient is having severe preeclampsia, then we can't go beyond 34 weeks. So that is the 34. So I put it in a stepwise manner. So I started with 34, 35, 36, 37, 38, and 40. So if you can just take it like that. So 34 weeks we deliver monoamniotic twins, twin-to-twin transfusion in monochorionic and severe preeclampsia. At 35 weeks we deliver triplets and vasa previa. At 36 weeks we deliver monochorionic twins and placenta accreta. At 37 weeks we deliver dichorionic twins, mild preeclampsia, type 1 diabetes on insulin, fetal anemia with intrauterine transfusion. At 38 weeks we deliver normal placenta previa, and for sure by C-section, and sickle cell disease between 38 to 40. And at 40 weeks we deliver gestational diabetes well controlled on diet and high maternal age more than 40. Okay, so here where we need to tell the patient you may need induction date at around for example 36 weeks if she is placenta accreta. Okay, so placenta accreta for sure she will have a C-section, so you will offer her your delivery will be by C-section and will be at 36 weeks. Okay, so that's how and when to plan for delivery. So the aim for everyone is vaginal birth like unless certain situation we may need to offer C-section, like monoamniotic monochorionic monoamniotic twin C-section, placenta accreta, placenta previa, both are C-sections. Okay. Previously also obstetric cholestasis we were delivering at 37 weeks, but now the new guidance came, so that has been changed recently, so I'll discuss it later separately with the obstetric cholestasis station. Okay. So usually when you see a patient who is high risk, you need to remember one sentence. You need to tell her that your antenatal care will be in a consultant-led unit under care of multidisciplinary team, consists of senior obstetrician, specialist nurse, and add whatever who needed to be involved in her care. For example, if she's like coming with a heart condition, so you tell her your pregnancy care will be in a consultant-led unit under a multidisciplinary team, consists of senior obstetrician, specialist nurse, heart doctor, and you may need more frequent visits and more frequent scans than usual. So that's, we may need to optimize your heart condition and scan your heart more frequently, like that. So you need to tell her like where she should come for her antenatal visit, who will look after her during her pregnancy, and why like we need more frequent visits and more frequent scans. Okay. And that's where to plan for delivery. So after delivery, we need to not to forget the postnatal care plan. So we need to discuss the suitable options of contraception, because sometimes like for example obstetric cholestasis, we are not allowed to give them estrogen containing contraception, so we need to notify her if she needs a contraception, she should avoid these estrogen containing medication. Okay.